right, good morning, everyone. All right, hello, everyone, and happy National Healthcare Decisions Day. For those of you who don't know, my name is Kelly Snyder. I'm the Director of Social Work here at Carroll Lutheran. We're very excited today to welcome you to discuss the importance of healthcare decision-making. Advanced care planning starts with conversation, consideration of your values and preferences, and what you would find acceptable in relation to your health or end-of-life situation. We're very fortunate today to have with us Mr. Paul Ballard, Maryland's Assistant Attorney General, and Dr. Eric Bush, Chief Medical Officer of the Quality Initiatives Unit for the Office of Healthcare Quality. So I'm going to let them go ahead and join me. We'll let them tell you more about themselves as we lead into learning more about healthcare decision making.
I guess I leave this. Can you hear me all right? I don't know if this moves out or do I just keep it here? Hi, I'm Paul Ballard. I'm an Assistant Attorney General on Council for Health Decisions Policy, and I do a lot of education on advanced directives, the MOLST form, end-of-life care issues from the legal perspective because I'm an attorney. But we're very fortunate today to have Dr. Eric Bush, and you get both. You get a lawyer and a doctor today. So
and we get along.
Yeah, that really is the most amazing part. So you see an unusual phenomena, out in the wild, an attorney and doctor getting along together, roaming Carroll County. Do we have the presentation up or? Oh, there we go. Okay. Okay, so I don't know, Eric, did you want to introduce yourself?
Sure. So number one, thank you for being here today. Thank you for taking your time. This is a very important discussion topic. Again, the goal of this is to help enhance, educate your informed decision making. What we want you to take away from this is the importance of getting advanced directives and living will done, because as you'll see throughout the presentation, in doing that, that's really the best way that you can advocate for yourself and the best way that you can advocate for your health care along the way as your trajectory of life changes throughout. So thank you.
Yeah, and it is very valuable to have Dr. Bush's perspective because he has seen all of these events happen as people have.
So just real quick, I've been in healthcare for 35 years, medic, nurse, pharmacist, doctor, worked here in Maryland for the last, prior to coming to my current position, for 16 years for a lot of hospitals, health systems, chaired ethics committees. So I see a lot of these things and the results of when people don't make their decisions known. So I think it's very important to make these things known, both written and verbal, to your loved ones and those that can make decisions for you at a point in life when you're no longer able to. Thank you.
And, we will be happy to take questions if something occurs to you. Also, remember that even after today's session ends, we're available by email, and there'll be a contact number. You can even call me. I can't give you direct legal advice because I'm not allowed to be everyone's attorney in the state, but a lot of times just basic information can help you, guide you where you want to go. So that service is out there. It's free to let you know. So let me make sure I got this going. Is this? Oh, that went to the end. Okay, now I'm worried about. That goes to the end. That's all the nice contact information I talked about. But where's each slide? Is it?
This one right here.
Here?
Yep, right there.
Oh, okay. Did I go? Oh, okay. All right. Now we've taken care of those technical issues. All right, so the thing to remember is, the most important thing to remember is you have control over your own health care. Okay, that's very important. Whenever you see a doctor now, they can make recommendations, and you can ask them, well, Doc, Dr. Bush, you'd say this is what I have, this is my problem. Will this surgery help me? After this surgery, let's say, will I be able to do things I still want to do? What will my life look like? What are the chances of its success? These are important things to consider when you think about any healthcare decision, right? So when you consider those things with information from your doctor, then he will ask for your informed consent. So you've been informed about what's at stake, and you consent to that treatment. Or you say, that's okay. I think I'd prefer not to have the treatment. I prefer to live my life without that, and we'll do alternate treatments, or we'll see how things go without it. These are all your choices. And so that's the principle we are operating from, that we all have that right over our own body to figure out what we want to do with it. Now, the problem comes in is when you lose the ability to make those decisions yourself. Then we have a problem, right? Because who is going to make those decisions? And what are those decisions going to be? And that's really what today is about, okay? So the ability you have to make decisions, in fact, I'm going to let Dr. Bush talk about this one, because this is really about your ability to make decisions. That's more of a medical issue.
Thanks, Paul. So as Paul's saying, medicine is very much like life. There's pros and cons with everything that we do in medicine. And where that interfaces with where you are in your life's trajectory at that point in time, that risk versus benefit ratio may change, whether it's based on your functional status, cognitive status. With regards to cognition and what Paul's saying about capacity from a medical perspective is, does the individual understand his or her current medical issues? And do they understand the implications of either escalation, so higher level of care, and or de-escalation of care? So if they're able to understand that on a basic level, you don't need to have medical jargon in your answer, but if they can tell you that, then they have capacity to make decisions on their own, which is really what we want, because we want people to be able to make those decisions for themselves, because you know yourself best. And as life changes for you and your experiences change for you, you are best able to make those wishes known. And so, also, obviously, healthcare is changing, and not just doctors, but any providers. So whether it's a doctor, nurse practitioner, physician assistant, whoever you have that relationship with, and I think it's great if you can to have a relationship with that provider over time, because they will be able to see the movie of your life, and they will be able to have those shared experiences with you, and they will best be able to have those discussions with you as things change. Let's see what we didn't cover on the slide here. Yeah, I think we're good.
Right, and so you can see this is kind of a lawyerly slide, because it's really going through what the elements of informed consent are, the ability to understand what's at stake with the decision and to be able to understand and make a decision that is informed, okay? And when you don't have that ability, then we have to think about who will make the decision for you so they can make an informed decision on your behalf. And so we'll be getting into how we do that. So there are a number of ways legally that this can happen when you lose the ability to make decisions yourself. You have the opportunity, and we have advanced directive forms that we brought today. You have the really the wonderful opportunity in this society, here in the United States of America, to take control of your own healthcare, even after you have that ability to make decisions gone. You can do it in advance. an advance directive while you can still think about this and what you want, what the quality of life you want, who you want to make those decisions. So when you think about who you want to make the decisions, we call that person a healthcare agent. So you're deciding who this person is. It can be anyone you trust, someone who knows you well, someone who you've talked to about what's important to you, what quality of life is important to you. And they can then make decisions for you confidently, having talked with you about what you value. If there is no advance directive, then the law is trying to get to someone who can make a decision to tell Dr. Bush, whoever it is, this is what we're going to do, so he can know how to treat. That person is called a surrogate decision maker. So the big advantage of doing an advance directive is you get to decide who will make those decisions and appoint them as your healthcare agent. And I'll talk about how we select a surrogate decision maker. And finally, a court could appoint a guardian of the person, to make the decisions for you. This may be a person who knows you well, and may not be a person who knows you well. But in the end, we're trying to get to someone who can make decisions on your behalf. Optimally, we want that to be the best person.
Yeah, and so just to touch on what Paul covered there, number one, we do the preference is always to have advanced directives, living will done, name a healthcare agent, because you can also help guide your care too in the kind of care that you want and the kind of decisions that you want your healthcare agent to make for you. That's really the preference. But if there is none, then Maryland has something called surrogacy, which falls into, it's a hierarchy with regards to who gets to make decisions based on their relationship in your life. But again, there are parameters that the state puts around what kind of decisions surrogates can make, because the state has to default towards preserving life, right? And so we always prefer if you have advance directives and living will done, because that is the best way to make your wishes known and have them carried forward. And then finally, as Paul noted about guardian, whether it's sometimes if we go through surrogacy and we can't identify anybody, then a guardian is named, or some of the other hats that I wear in my current job say individuals that are engaged with Developmental Disabilities Administration. A lot of times they have guardians.
Okay, so there are many approaches we can take to this. Okay, we can just let things go, hope things work out for the best, make assumptions about what our family knows about what we want. Oh, they'll know what to do, they know me well. Maybe. You would be amazed how little your family knows what you want to do. Okay. So it's important to talk with them, but the advance directive is also important because it can help them remember what we talked about. You know, oh yes, I talked with Mom, I talked with Dad about this at Thanksgiving or wherever it was, and she said that, and he said that, oh, and that's what the advance directive says. And that is nice, because sometimes, unfortunately, what I've encountered in my practice is incidents where the family member never even saw the advance directive, and they were appointed as an agent, or their mother was appointed as an agent, but they were never told what was in it, and now they're the backup agent. Or now they're the surrogate, but they didn't understand that this is what their loved one wanted, and you get all kinds of conflict. I don't know if you have any example of that from your practice.
Yeah, no, I've seen that, and sometimes, unfortunately, too, you have those that don't necessarily follow the written directives. But again, I think, to me, the main takeaway point here is to make sure that you have your wishes in writing, and then also verbally communicate those to those around you. And we realize, obviously, these are hard conversations to have, but there are more and more resources out there. Obviously, you know, speaking for the state, we can't endorse any particular entity or modality, but there's things such as the Conversation Project that really tries to help you prompt how to have this conversation with your family. Okay,
so like I said, ideally you want to appoint someone as your healthcare agent and do an advance directive. If you don't, we're going to get to a decision maker. The law is going to come to somebody. And the way it gets there is through surrogate decision makers. And it goes through this priority list you see on the slide. So it begins with the question, is there a guardian appointed by a court? If there's a guardian appointed by the court, that's going to trump everybody else. That's really the person acting under the court order. But assuming there's no guardian under a court order, we're looking first, is there a spouse? If there's a spouse, that's the priority decision maker. Now, you have to be careful there because some people may still have a spouse they haven't seen in 20 years. They never got divorced. Okay, so that's their first decision maker, your ex. Get an advance directive. Appoint an agent. Now, they may not want to be your agent, but they have a right to say, I'm the agent. Give me that decision. And then you might have a domestic partner. And a domestic partner is someone you're living with. You're not married, but you're in a committed relationship that's short of marriage, and you're sharing expenses, and it's a boyfriend-girlfriend relationship, or boyfriend-boyfriend or girlfriend-girlfriend. It doesn't matter. The point is that they are intimately involved, and they live together, and they share expenses, and they have commitment. This is a domestic partner, and they actually take priority over adult children, okay, which can create some conflicts. What, my mother's live-in boyfriend is going to make life and death decisions for her and not me? So this is another possible potential source of conflict that you can take care of doing an advance directive. Appoint a healthcare agent, appoint backup agents. If there's no spouse or domestic partner, then you look to adult children. Now, of course, adult children always agree on everything. I mean, I never fought with my brother growing up. Yeah, right. We're a lot closer now, but we still disagree about things. So it's very common that children are going to disagree. And especially if they haven't really been talked to about what these issues are. No one talks about this in our society. We don't talk about this. So they're going to jump to conclusions, and they're going to jump to conclusions that they want. I think she would want this, or I think she would want that, but it's really a lot of their own thinking that's coloring those decisions, not necessarily what the parent really wanted. So, and these surrogates, all the adult children, they all have equal decision-making authority under the law. So they all have to agree, okay? And if they don't agree, then we do have a way to settle that disagreement. We have what are called ethics committees, patient care advisory committees, and Dr. Bush has sat on those, right? And you can explain that, but they will actually listen to everyone involved and say, why do you think your mom would want this, or why do you think your dad would want that? And then they make a decision, and they say, okay, go ahead and do that. But in the meantime, there's this legacy of bitterness, about what happened. I don't know if you want to talk about the...
Yeah, so again, with regards to surrogacy, so just to highlight some of the things Paul was talking about, you may end up with a surrogate who doesn't necessarily view things the same way that you do. The other piece, too, is looking at this through a medical lens, and what I've seen clinical experience-wise, unfortunately, you don't know what's going to happen each day, right? Sometimes you can have a heart attack suddenly, you may have a stroke suddenly, and if you don't have your advance directive or living will, then you end up having to go through the surrogacy chain, which is, number one, not always the best for the patient or individual who's receiving the care, but number two, also for us in the healthcare system, very time intensive. Our social workers, case managers, sure can speak to, nurse case managers. It takes a lot of work, a lot of times to figure out who the surrogate is, and then also to ascertain that they do have that individual who's receiving care, their best interests at heart. And then as Paul is saying, the state, I think, has done overall a great job trying to accommodate all these different things that may happen. But ethics committee, patient care advisory committee, again, this is often when you have surrogates that then there is gaps in communication, or they don't have a clear perception of what's transpiring with that individual's care. And those have been in action for hospitals since 1987, and skilled nursing facilities since 1993, but it's a lot of work and a lot of effort when really all that could be avoided if somebody had advanced directives of living will done. You can avoid this whole chain of surrogacy.
Yeah, and that's another huge consideration is how are the healthcare providers going to interact with all this? So, because that will affect the care you have. So, if there are no more adult children, then you look to parents if they're still alive. If they're both alive, they may disagree. You look to adult siblings if they're not, the parents aren't around, and it's the same process. Then finally, a close friend or other relative can sign an affidavit saying, I know enough about what this person wants and believes in that I can make these decisions. And in the absence of all these folks, they can give emergency care without consent to save your life, but it's really hard. They can't do proactive things, get tests and things unless they have someone to consent to this or some way to know that someone is saying, yes, go ahead and do this. So deciding in the dark is hard. There's a risk of disagreement. All these surrogates of equal rank have equal authority, so that creates issues of practical issues, and then they might fight with each other about these problems, which is a problem. So you have a legacy of guilt, anger, bitterness, or anxiety that can result from not doing good advanced care planning. So let's take an example. Mr. Green, he's a 82-year-old widower with 3 children, former smoker with end-stage lung disease and worsening Alzheimer's disease, who lives in a nursing home. He can't make his own healthcare decisions, and he's had some recent breathing crisis. He keeps getting sent to the hospital. He goes on and off a ventilator. His prognosis isn't good. He's requiring more trips to the hospital, and death is probably likely within several months. So the question for the children is, well, would your father want resuscitation to be attempted? I don't know if you want to talk about what is involved in
Sure. So goals of care discussions, and again, risk-benefit, medicine just like life. And so if you look at even in-hospital resuscitation over the last 20, 30 years, it's still in just about the 20% range. So if you have a heart attack, if you have a code in the hospital, your chance of being revived in the hospital where medical providers are, it's about 20% if you look. It varies a little bit depending on the hospital and series. Now, that being said, what would this individual's wishes would have been if he was cognitively aware? Also, what was he like characterologically? And that's why it's important, again, if he had advanced directives living will. If not, then at least to talk to as many family members or people who knew him and knew his whole life trajectory and what his wishes would be. So things like CPR obviously can be very beneficial if you have somebody who didn't have a lot of comorbidities or was young previously or had good functional status. Chance of resuscitation pretty good, recovery pretty good. But in someone, sometimes as diseases, especially this individual with multiple diseases, cancer, dementia, where you tend to have weight loss and you have a very thin chest, just the risk of causing trauma to that individual, the family, as well as the providers that have to do CPR, that is a huge risk, and that's something that needs to be stated in discussions with the family. And that's not, saying overriding anybody's wishes, but these are things to me that need to be considered in that whole balance of that risk versus benefit discussion. And again, just like we talked earlier, that's why it's important and great if you do have a provider that you've had a relationship with, because then that's somebody else that can weigh in on all these things and say, this is what I know Mr. Green would or wouldn't have wanted. And if his life had changed like this at this point when I started to know him 5 years ago, 10 years ago, 20 years ago, what he would want. To me, that's the importance of it.
Right. So these are questions, whether he'd want to be transferred to the hospital, whether he should go into hospice. And so the elder daughter says, oh, Dad was a fighter. You should do everything to keep him alive. And the younger daughter, Dad wouldn't have wanted this. He's suffering. It's time to stop. And they all could be right in some sense. They all might be drawing upon experiences they had with their father and coming to conclusions. But they might also just be coming to conclusions they want to come to for their own reasons. So it's hard to know. It's hard to know what they want. They're trying to figure out, well, at the end of the day, we want to do what Mr. Green would have wanted to do. That's what the object of the game. And what would he want to decide? So we're trying to figure that out. That's going back to the beginning when I talked about this is all about, exercising your own right over your own body. Well, we're trying to do that for Mr. Green in this situation. So the talk, it's very good. It's actually essential. You've got to at least talk with your loved ones about what you want. If you don't, at the very least have a living will so you can have it in writing what you want. But even then, they might not believe what's in the living will if they haven't heard it from you, so it's helpful to have that, both. And memories can fade, as the document can help them remind, oh yeah, right, that's what we talked about. And plus it gives some comfort to doctors and the healthcare team. Oh yeah, we have a living will, it says this is what we're doing, or it's consistent with what they want. So don't wait till it's too late. Talk with your family and friends about your preferences and document decisions in a legally valid way. And in Maryland, it's not that hard to do that, really. All you need to do is sign in front of 2 witnesses the advance directive and date it. You're done. That's it. That's the advance directive. So it's not complicated. It's not, you don't have to go to a notary. You don't have to go to a lawyer. So it's very well straightforward. So the types of advance directives, you're saying in an advance directive you can appoint someone to be your agent. You can do a living will to say, in the event of this is what I want or don't want. You can do both. You can do either or do both. Keep in mind, when we're talking about a medical advance directive, we're not talking about a financial power of attorney. That's a different document. That's about, if you lose the ability to make your decisions, who's going to handle your finances? That's a whole different thing. My recommendation is that you keep those documents separate. I mean, you could have them in one document, but I think it gets confusing because they have different requirements. For instance, you have to have a notary for the power of attorney. You don't need one for the advance directive. It's just there are all these little differences. So it might be better just to have 2 separate documents to keep it straight. But just keep in mind, just because you've done a financial power of attorney doesn't mean you have a medical advance directive, because sometimes the financial powers of attorney are just very general language, can hire doctors. Well, hire doctors doesn't mean I can make life and death decisions for this person. It just means I can hire doctors. So be careful about that. What will be done or not done, so you can decide, often people do an advance directive because they're concerned they're going to get too much care. Some people do it because they're concerned they're not going to get enough care. So you can put whatever you want in it. Healthcare agents, it's up to you to decide how much authority you want to give the agent. You can say, I've done my living will. You are going to follow it to the letter. I don't want you to depart from it. Or you could say, I trust you. If you think in this certain circumstances it's in my best interest to do something that departs from what I've said here, I trust you. I'm giving you that authority. And that option is in the state form that we have copies of there. But regardless, what everyone's trying to do is carry out your wishes. And if we know what your wishes are, if they're clear, that's what we're doing. We're not imposing our own values on you. It's only when we don't know what you want, then we look at, the healthcare agent looks at, or the surrogate looks at what is in your best interest. Is this treatment worth the pain and aggravation it's causing, or the quality of life problems it's causing? We also have a proxy handbook that's available at the Attorney General's website, and a call also can be mailed to you if you want. And that's to guide surrogates and healthcare agents, and it was done in coordination with the American Bar Association. I think it's a very good and helpful document. It's really called Making Medical Decisions for Someone Else, I think is the official title. So a living will, basically with a living will, you're kind of looking into the future. You're taking your crystal ball and saying, if this ever happens, I want this treatment or I don't want this treatment. It could be talking about CPR, it could be talking about ventilators, feeding tubes. You may also say, I want everything done. Keep in mind that any decision can be made by your healthcare agent. If you give them complete authority, that's another advantage to doing an advance directive. You can give them as much authority as you want. If you give them complete authority over every decision, including all life-sustaining treatments, it's as if you were talking. Okay. The surrogate decision makers are not given that kind of broad authority. Okay. There wasn't the same level of trust given to the surrogates by the Maryland legislature when they did the Healthcare Decisions Act. So they thought, well, if it's a surrogate, if it's someone they have not chosen themselves, they can only consent to withholding or withdrawing a life-sustaining treatment. For example, they could only consent to a do not resuscitate order if the patient has been determined by two physicians, or now a physician and a nurse practitioner, to be in a terminal condition, an end-stage condition, or in a persistent vegetative state.
Yeah, so we just changed gears here, and before we move on from advanced directives, just a couple thoughts. Number one, there are ways in your advanced directives to give some latitude to your decision makers, because again, when I think through these scenarios medically, absolutes, I could think of cases, let's talk about IV fluids. I want absolutely no IV fluids. Well, if you had somebody who was pretty functional and they fell and say broke a hip, but they had some muscle breakdown, one of the first things I want to do as a doc is give them IV fluids. So if you say, no, I don't want IV fluids, that's kind of against. So, but if you had latitude in there to leave it up to your decision maker, to give them IV fluids, versus conversely, say if I had somebody who had a history of heart failure and now is in an exacerbation, but they say, I want IV fluids no matter what. For me to give that individual IV fluids is actually going to make their condition worse and make their symptoms worse. So again, I think there's a way, and there is a way within the advanced directives to give your decision maker some latitude, and just something to think about, because again, things do change over time. With regards to what Paul's talking about here, this is now surrogacy. And what the state did with the surrogates is put on them qualifying conditions, number one, of conditions. So they have to be either in terminal, end stage, or persistent vegetative state. And then number two, capacity. So they also have to not have capacity for the surrogate to then start withdrawing care. And that's what we're talking about here.
So for these conditions that only a surrogate can only withhold or withdraw life-sustaining treatments for, they're limiting the surrogate's authority. So, for instance, to be in a terminal condition, death has to be expected very soon, in a matter of days, weeks. For the surrogate to say, no, I don't want CPR, or no, I don't want a ventilator or feeding tube. An end-stage condition is the example of that. Maybe you want to give some of that.
So end-stage condition, so number one, terminal condition, a lot of people think about, the hospice definition. If the disease were to follow its expected prognosis, life expectancy 6 months or less. The way it's used here, the previous slide with regards to terminal condition is probably more days or weeks. Could be up to months, but more likely days or weeks. With regards to end-stage condition, this is, the state's thought was progressive neurologic, especially dementia, so Alzheimer's, Lewy body, frontotemporal, but any type of dementia, vascular mixed dementias, as well as other progressive neurologic disorders, things like multiple sclerosis, Lou Gehrig's disease, or ALS. Those kinds of things are what fall under end-stage condition, where it's progressive, irreversible, complete physical dependency, so not able to do any of your daily activities of daily living. And death is not necessarily imminent. This is something that can go on sometimes for months, maybe even up to a year. I've seen sometimes, especially ALS or end-stage MS patients, or even dementia, and advanced dementia, or perhaps similar condition. Sure.
Yeah, so this is something that quite often is in an advanced directive, refer to this condition to say, no, in this condition, I don't want that treatment. And so it's a way to make sure that you don't get life-sustaining treatments if you don't want them in those conditions. Persistent vegetative state. If you remember Terry Schiavo, I think that was one of the very high-profile cases back in the 2000s. And to me, that's a very good lesson in the importance of advanced care planning, because the family was fighting. It went to the Supreme Court, it went to Congress, it was on the nightly news for weeks. And when people saw that news every night about what was going on with all this fighting about this poor woman, I think in her 30s in this state, we got inundated at the Attorney General's office with requests for, guess what? Advanced directives, yes. Because everyone was looking at what was happening to this woman and their family and thinking, I don't want that to happen to my family. This is a nightmare. If she had just done an advanced directive, we wouldn't be going through all this. So sometimes it takes cases like that to raise your consciousness, but that's a good case. But that was what she had, was a persistent vegetative state. And she was in this coma, and she could have lasted for quite a while. And she was just reflexively reacting, no real consciousness of what was going on.
On the other hand, this is something that we do get questions about, and so wait a medically appropriate period of time. It's got to be at the very least, very minimum, a week, because sometimes people do have strokes but then subsequently recover, and we don't want them to be misdiagnosed. And that's part of the problems with persistent vegetative state, is there is a high chance of it being misdiagnosed. So one of the other caveats to this is one of the people that diagnoses this has to have advanced training in cognitive functioning, i.e. either a neurosurgeon, neuropsychiatrist, or neurologist, somebody that's very well skilled in making this particular diagnosis.
Basically, everybody who reads a living will, who is the agent that's trying to carry this out, or if they're a surrogate and they see the living will and it was just a living will, they're trying to follow what that living will said, because it's really the best evidence we have of what the patient wants. They took the trouble to prepare this advanced directive, sign in front of witnesses. We think they wanted it carried out. So that's a really good evidence. You can decide in living will, like I said, whether you want to bind your agent to all these things or whether you want to give them latitude. Again, the formalities are very straightforward. It's 2 witnesses. You don't need a notary. The statutory form, which we have over here, is optional. You can use other forms like 5 wishes or my directives or whatever it might be. They're all valid. And also, out-of-state advanced directives are valid in Maryland. So if you did one in Pennsylvania, it's recognized in Maryland, for instance. I can't guarantee what other states will do with Maryland's. It is typical, though, that states will recognize each other's advanced directives. And I think that one of the reasons for that, too, is that every state has the commonality of carrying out what people want. And the best evidence of that is the advanced directive. You can change or revoke your advanced directive any time. It's presumed valid. It never expires, but that's why you want to look at it every now and then, because your wishes might change. If it's a new one on the same topic, then it changes the old one. So if it's a newer date, we can assume that you got a different view now, even though one is still out there. It's good to destroy any old ones that you don't want out there so they don't appear in a way you don't want them to. And only you may change it. Your friends, family members can't say, oh, I don't like this directive, I'm going to do a new one. No, it's you. So once you do lose the ability to make decisions for yourself, keep in mind, that's your directive. And from the state's point of view, if you had a living will, we're going to carry out that living will. We're going to enforce that living will as it is. So it's good to review what you said and make sure it's up to date with what you want.
If you do decide to change your advanced directive or living will, please communicate that both, again, written and verbally.
You want to review periodically, make sure the agents they might have died, they might not be around, you might want to do a new one with new information. The contact information needs to be correct so that it can be useful, the advanced directive can be useful. And whether your care preferences are the same, you might have a different view. You need to discuss it with your healthcare agent. That happens, they don't talk to their healthcare agent and say, hey, do you want to be a healthcare agent? This is what I want. It's very important. They need to know what you want. I know, the family member might say, I know what it says, but I don't, but she didn't understand. You know, they're like, they can't believe that they actually meant to say this. So that's why it's important to talk with them as well as write it. Stay away from ambiguous language, no heroic measures. I don't think that has a lot of meaning to medical professionals.
No heroic measures, comfort care, quality of life, because two doctors can't agree on that, much less a doctor and an attorney. So.
Well, I know what it means. I don't know why you don't. And then,
Yes,
are
sir.
you sure about a treatment decision? That's the, are you still sure about that? Things change. Things change. And there's an old Mexican proverb, the appearance of the bull changes once you enter the ring. Okay, so it's all very fine and good to talk about what you want in theory, but once you're facing the actual situation, you might have a different view. And if you do have a different view, then you want to change your advanced directive. So you want to give copies to your family, to your friends. Wallet card is good because a wallet card you can say, I have an advanced directive, this is my agent, they can be contacted at this phone number, they have a copy of my advanced directive. We also have a registry. You can go to mydirectives.com and upload your directive onto that, and then your provider can find it on CRISP, which is the state sharing of healthcare records so that they can access them when they need them. And it's more technically that I understand, so I'm not going to.
You're fine.
Yeah.
So CRISP is short for Chesapeake Regional Information Sharing for Patients. It's a health information exchange, i.e. it's electronic. It interfaces with multiple states, multiple health systems, so you can actually get your Living Will advanced directives in there, as well as your Maryland MULST can have that uploaded. And then this way, if you do go to one of the hospitals, regionally, locally, they would have that information on file.
So you want to make it work in the real world. So if you have a current health issue for which you want a medical order to carry out your wishes for care, you want to, if you have current issues, if you have current conditions that require a medical order, you're going to want a MULST form. Okay, so keep in mind, the most important take-home point from this is, let's say you don't want to be resuscitated. Well, simply putting that in an advanced directive isn't going to do it. You need to have an order. You need to have a do not resuscitate order in a MULST form. So just remember that. In terms of, we're going to talk more about MULST, but I do have contact information about the Attorney General's office, and because we do give information on advanced directives, we give the free advanced directive, one per person. We'll mail to if you want. And now we're talking about the MULST form. And I think we had MULST forms provided. Was that right? Okay, so it's helpful to see it. But the idea of the MULST form, it was created in 2011, was to have a medical order form that embodies your wishes, that is immediately something that any healthcare provider in the state can act upon right away. Okay, they see your wishes, they're in the form of medical orders. So it's not like an advanced directive. Advanced directives are wonderful. We've talked about how great they are. But for a very emergent situations, you need a MULST form with an order. The advanced directive doesn't have medical orders. So it's portable, it's indoors, it's valid in every healthcare setting, and because everyone recognizes that as an order, no matter where you are, it increases the likelihood your wishes will be carried out. You can get a form on the Maryland MULST website at marylandmulst.org. Also, the Maryland Institute for Emergency Medical Services Systems, you can call them and get one as well. And why do you need both a MULST form and advanced directive? This is a question that I get quite a bit. So basically, the healthcare system, maybe you can tackle this one.
Sure. So the healthcare system works based off of orders, right? That's one. 1A is if you think about when somebody codes or they have a heart attack, they're not responsive, how quickly emergency medical services, that emergency medical technician needs to act. So they need to see right away, because within seconds, minutes, the more that your blood is not circulating, oxygenated blood, you lose brain function, heart function, end organ damage. So this is something that the medical system can act on, which is much different than an advanced directive living will, right? If somebody from an EMT is coming to give you help, they don't have time to read through 8-10 page advanced directive living will. They need something there right in front of them, black and white, 1-2 pages. Do I do it or do I not do it?
Right. So basically, the way I like to think of it is the MOLS form is things about things that are going on with you now, at this moment. This is an issue that is important to you right now. I'm having swallowing difficulties. I have a MOLS form that contains an order about feeding tubes, or whatever it might be. Whereas an advanced directive, I'm perfectly healthy today, but I want to make my wishes known that in case someday, this hypothetical situation, I'll be in this situation, so you know what my wishes are. Okay, so I don't know if you want to go through these briefly,
Sure.
how the form works.
Great. So I'm going to move a little more quickly here. So the MOLS form, basis for the orders basically is who the individual that was spoken with and who the provider was that spoke to them. So whether it's an NP, MD, and who they spoke with within the family, whether it was the individual themselves, a surrogate decision maker, somebody named in the advanced directive or living will, and what the basis for those orders are. Because again, since this is a medical order, just like any other medical order, you want to make sure that it's well documented who had the conversation and who that conversation was held with. Okay, so instructions of the patient's advance directive, other legal authority in accordance with the Healthcare Decisions Act, and we're not going to get into that today, but that's with regards to medical ineffectiveness, which is a whole other topic in and of itself. What if the patient declines or unable to make a selection? By all means, that's their right, but that individual, you can just draw a line through that. That individual will be a full code. So again, you can't say that I don't want anything done if something were to happen to me, but then I don't want to fill out a MOLS form, because if you don't fill out a MOLS form by default, again, emergency medical services has to try to sustain life for you. What orders do EMS providers follow? Again, it's just the MOLS form itself is a 2-pager. It's really just the first page. Again, things happen in real time very quickly. And this needs to be acted upon quickly. So they need to see what that individual wants done, what level of support they want, whether it's full resuscitation, whether it's something such as, BiPAP or CPAP, but not intubation, and what they should do. They're looking for guidance immediately as soon as they arrive on the scene, and they're triaging what to do or not do at that time and follow that individual's wishes. So Section 1, CPR status, attempt CPR. Again, if you have cardiac or pulmonary arrest, you will do CPR. No CPR option A1, intubate. Comprehensive efforts to prevent arrest, including intubation. This is something I've had individuals choose this, and I've asked them exactly what the rationale is for this, because this also isn't necessarily sustainable because you're being intubated but not necessarily having resuscitations, which also is incompatible at some point in time. So I see this as another, one of the things I like about MOLS and advanced directives and all these forms is it really prompts conversations, to get from patients, individuals, families, exactly what their wishes are and help you delve further, because again, at the core, what you want is that individual receiving the care that they want. Next option is no CPR, option A2, so do not intubate. Again, these are individuals that don't want intubation, and this can be very helpful for individuals with emphysema, COPD, CHF. I've had a lot of individuals even that were very sick that have still received these treatments that are non-invasive in nature, and help get them through an acute episode of a chronic disease that they have. And then finally, the last option, no CPR, option B, palliative and supportive care. And this does mean, focused more on comfort. However, that shouldn't preclude somebody, say, from getting, oxygen via nasal cannula. So somebody getting a couple liters of nasal oxygen, even if they're at the very end of life, that is not going to prolong their life, but likely provide them some comfort at that time. So now this is the back of the form, starting with Section 2, artificial ventilation. And again, accepted indefinitely, including CPAP and BiPAP. Limited trial of intubation, time-limited trial of CPAP, BiPAP, and no intubation, and no artificial ventilation. Again, that means you can still get oxygen, just not the larger bore tubes or not a tube placed down your throat. And again, just like we talked earlier, risk versus benefit, these things should prompt discussions with your family, your loved ones, hopefully your healthcare agent that you have in your advanced directive of living will, and what the risk benefits of these things are at that point in time. Blood transfusions, again, this was put in there because there's some individuals, religious beliefs that don't want blood transfusions. The other piece too is there are some people that have had a lot of blood transfusions over time previously who now have antibodies to blood, and where there actually may be some risk versus, the benefit for having that done. Again, these things should all prompt discussions for individuals and where they are at that point in time in life. Hospital transfers, except hospital transfer only for limited situations, or no hospital transfer. And again, the other piece, this does need to be congruent. So say if you have somebody who is at an assisted living facility and wants to be a full code or have everything done, but then doesn't want a hospital transfer, that's something that we can't have, right? Because if you want that done, and that's fine, you cannot receive that level of care at an assisted living facility if you need to be intubated and ventilated. Medical workup, accept any tests, limited medical tests necessary for symptomatic treatment or comfort, and none for diagnosis or treatment. Again, at the individual's discretion, all different risk versus benefit. Antibiotics, accept oral antibiotics only, oral antibiotics for relief of symptoms, or none. Again, I think just highlights antibiotics are very much a challenge. It's because of the antibiotic resistance we have and overprescribing, it's scheduled to be a top 10 cause of death in this country by 2050. So just something to think about, antibiotics and how and when and where and what route. Artificially administered fluids, nutrition, again, like we talked earlier, those two situations, the lady who had the fall who could benefit from IV fluids, the gentleman with the heart failure who fluids may be, deleterious. And again, as we spoke, great thing about advanced directives living will, you can give your decision maker some latitude about, hey, I'd like some IV fluids if it would be beneficial, but give them the latitude also to decide when that's going to be beneficial or not. All right, dialysis, accept dialysis, hemo, and peritoneal, limited trial or none. And then finally, other orders. Again, we talked about this, touched upon this. No ambiguous phrases, please. Comfort care, focus just on quality of life. If you want something, again, radiation or chemo, if you're going through that, by all means, that's fine. Radiation therapy, 10 treatments, or, per my radiation oncologist. Those are all reasonable things. Those are concrete. Those are things we can then discuss. We just don't want something ambiguous in there. Does a choice have to be made in each section? Again, section 1, the front page, CPR. Yes, we do. If an individual declines to make a decision there, they are a full code. Section 2 through 9, the back, you don't necessarily have to complete that. Patient changes his or her mind, absolutely, that's their right to. And then they can have a discussion with their physician, NP, PA, healthcare providers, social workers, case managers, and make those new needs known. But again, please make sure to communicate that and update your forms. And is copy of most of a valid order? Absolutely. Original copy and a fax, all valid. Should make a copy In case you lose the form, again, there's a lot of tools now where you can turn these things into, PDFs via your phone and carry it with you. And I think that's, one of the great things with technology. Legal requirements. So it must be completed if you're in one of these, or transfer or transition between these different venues of care: nursing home, assisted living, home health, hospice, dialysis, as well as hospitals for certain patients. And yes, by all means, patient and or family, healthcare decision maker, surrogate does get a copy, and they need to have that. And where is it kept? At home, bedside, bedroom door, on a refrigerated door. Again, somewhere that you think that somebody who's going to have to give you, going to provide care for you immediately, where is the best place that they can see it as soon as they walk in to my residence? That's really the best place to put it. And there is a multi-CNR bracelet. Plastic may be ordered. Really, they kind of wear down over time, so the medical alert ones really are better and more sustainable. And there you go. There's Paul's info again. There you go, buddy. Thanks.
And that is our presentation. If anyone has any questions, we can take some. Yes.
You mentioned a temporary agent making decisions. How does the form instruct on how you determine whether or not, if I was the patient, have returned to be able to make my decisions after someone else has been making them for me?
Good question. I'll let Dr. Bush.
Sure. So that's a great question, and what you're talking about is capacity, waxing and waning capacity, right, which capacity can fluctuate over time. So that is something, especially in an acute care setting, say like the hospital, that should be assessed on a daily basis, because individual has dementia, but more moderate, not necessarily severe, but they have capacity for decision making. Then they get something as simple as a urinary tract infection. A day later, they're delirious. But then 2 days after receiving antibiotics, they may have clear mentation again. So again, that's something that does need to be ascertained depending on the setting, different time variables. Again, within the hospital, I would expect that that's done, daily. You've got a whole team there, bedside nurse. A lot of times you have pharmacists around, in addition to docs, NPs, hospital team. So yeah, that's something that does happen. And to answer your question, it's hard to tell how long your temporary agent or surrogate would serve. If, let's say, you didn't have advanced directives of living will, how long your surrogate would make decisions for you. It would be only until you have capacity again. So let's say best case scenario, you had a UTI, you got somewhat delirious, you got some antibiotics, a couple days later you have capacity again. You should be able to make decisions for yourself that day when you have capacity again. Your team at the hospital. So your nurse practitioner, doctor, nurse, those are all individuals who can assess medical capacity.
And just to follow up on that from the legal point of view, part of what the role that the Office of Healthcare Quality plays is they survey facilities, and if they are not keeping on top of that kind of thing, where they're letting someone who now has capacity again still be governed by a surrogate or healthcare agent, they're not going to be happy. So the facility has to have a way to handle that situation and say, hey, if I've got a patient who's now has capacity, I'm talking to that patient, I'm not talking to their decision maker.
Yeah, and to touch on just what Paul said there, so one of the other hats I wear from where my clinical piece interfaces regulatory, from assisted living through transplant surgery, we at the Office of Healthcare Quality regulate all those different care settings, venues. And so unfortunately, sometimes we do have individuals that their wishes were not observed, and that is something that we take action on, because these are things, again, we want to make sure that you're getting the care that you want and you put out there. So.
Because Maryland takes a life-preserving approach, can you explain kind of the timeline for establishing surrogacy and guardianship for those who don't have a will in place? As far as how long it takes?
You want to talk to that? Okay.
So from a clinical perspective, it depends, right? Because sometimes you have people who come into the hospital who clearly they don't have capacity for decision making. Sometimes you have people where it's shades of gray and then it takes longer. So those that don't have capacity, I mean, that should be something within a day or two that you establish that you need to get to somebody who's a surrogate to make decisions for them, versus those sometimes where there's those stipulating factors. I mean, sometimes it does take weeks to figure out, you know, who a surrogate is and who the appropriate surrogate is, just based on, I see we've got a little visitor here, just based on, you know, how that whole communication goes, because, again, it can take some time if you've got a John Doe or a Jane Doe, so to speak, and you don't have any information, and let's say they have end-stage dementia and can't give you any information, it takes a lot of time to figure out exactly who's going to make decisions for them and who the best one is to. And then the other piece clinically is obviously what's the trajectory of their current illness, right? Are they there for something maybe like a pneumonia but getting better, or did they come in with, say, a severe stroke and they're completely debilitated, you know, something that's more, that's larger in nature. You're welcome.
And just to give you a legal answer too, is that we always look for the Healthcare Decisions Act at each decision on its own. So as opposed to a guardianship where you have broad authority to make any decision, the surrogate is really about, we have a discrete decision we need made. Do we have someone with the capacity to make it? If not, someone else has to make it. Or if there's no one to consent, we might have to give the treatment. And if there's no advance directive where you said, I don't want this, you might have to give the treatment.
Yes, I basically have, can you hear? Two questions. You talked about if you have an advance directive to put it into a registry. Could you talk more about that, and also about the wallet card?
Sure. When I say registry, I guess that wasn't quite the most accurate term. It's kind of the common parlance, but the way they work in Maryland is they have this website called mydirectives.com, which is the one vendor that's recognized in Maryland to take advanced directives electronically and link them to this CRISP, this database, this health exchange. And so in order to do that, it's important to talk with your provider about making that happen. The wallet card is helpful because that's kind of the old school way of doing things. The idea is that you go to the hospital and they can't talk to you, but they can look through your wallet for insurance cards or whatever they're looking for, and they can see, oh, there's an advance directive. There is something here. There's a contact information. And we actually, there are many places you can get them, but we do have wallet cards on the Attorney General's website if you want to download them or if you want us to send you a copy. Okay.
A question about MOLST, please. Once the form is filled out and signed by the physician, then maybe 10 years has gone by and you don't go to that physician anymore. I had heard that any physician who is licensed in this state, the MOLST form is good no matter how long ago it was. Is that true?
Yes, the MOLST form doesn't expire. Now, there are requirements to review it.
Yeah.
At least no longer than every year if you're in a facility. Now, if you're at home and you've got this MOLST form, no one's going to be required to review it. If you generally the reason you might have it at home is you might want it the CPR, the DNR order, and that's going to stay valid. But as I don't know if you want to talk to what the practice concerns might be.
Sure. I think just from a clinical perspective, let's say it was signed a while ago and that physician or NP is now retired. I think it's good you can even bring that into the new physician or provider's visit and have that updated by them, because then it's good. Say I'm a hospitalist working in a hospital and this individual comes in, I get the MOLS form. At least I know who that provider is that signed it, and I can have a conversation with them about, the rationale why they chose what they chose and all the options, especially once you get to page 2, because page 2, sometimes, things change and providers have different perspectives. It's always great to have somebody that's current out there, so to speak to clinically.
Thank you.
Thank you.
This is why I love having him here.
Thanks, Paul.
Because I can give you these very legal responses, but he has the practical real world implications.
Thank you.
Yes.
Having trouble visualizing what happens in pre-hospital care. Yes, I have a MOLS form on the side of my refrigerator like we're all supposed to, but if EMTs are coming into a very emergent situation where someone is in cardiac arrest, are they going to really take time to look for this MOLS form before they start CPR?
Oh yes, they do. Absolutely, they have to, because there's a whole, it's not just, and full divulging, my daughter's an EMT, so yeah, there's a whole chain of command above them, what they can or can't do. It is absolutely the first thing that they do.
Okay. And one other question. This has been a while ago, but I have seen episodes more than once in a hospital situation where there is no advance directive and the family is making decisions that probably aren't medically valid, and they want everything stopped and the physician overrides their wishes. Is that okay, or how does that work?
Well, from what you're describing, that is not okay. And that is, because again, as of 1987, every hospital has a patient care advisory committee or ethics committee. 1993, all skilled nursing facilities in the state of Maryland. And those are things that, ethics committees are interdisciplinary. So it's not just physician, there's nurses, there's often chaplains, community representation, and that's good. And that's something that should be reported to that hospital's ethics committee. Anytime you have that divergence where you have, questions on either side or sometimes both sides, what the motivation for those decisions and what the basis from a medical legal perspective is. So at least clinically, I'd like Paul to weigh in on that too as well.
Well, it really depends on the particular situation. You can have really nightmare situations where you have care that's given completely opposite to what the person wanted. And that's why we're here today. That's really why we're here today, because you can prevent so much of that with good advanced care planning. But yeah, we've seen some real problems out there, so that's what happens when people don't really communicate well with each other about what they want, and then you end up with situations that were not what people wanted.
Sometimes, I guess what I'm thinking of is
Yeah.
sometimes families don't understand the medical perspective of what's going on, and the physician is making what would seem to me a valid decision.
So that's a communication issue, do you think? Or?
Yeah, so I was at one of the hospital's health systems that I worked at. I was the chair for their ethics committee for 6 years. 99.99% of these issues come down to communication. And a lot of times there's a gap because providers don't always often take the time it's not only the time, but also to speak in layman's terms that can be understood with the family about exactly what's transpiring. And so one of the things that I found most effective is prior to having that full-fledged ethics committee meeting, which is a very formal thing, I would actually mandate a family meeting where the attending doctor and any of the consultants, NPs, MDs had to be there, as well as family representatives, because that's often how you get to the core of the issue, and you get these divergent opinions because people are just getting snapshots, unfortunately, and they just look at the facet of care that they're providing, not necessarily the whole picture. Thank you.
Is there a relationship between a regular will and an advance directive or a living will? No. It's a very common question because of the terminology, but the living will is about what happens while you're alive, what kind of care you want. The will is after you die, who gets what property is essentially the difference. Now, that said, in terms of, there is a provision in the state form about I want my body disposed of this way or that way. I want my healthcare agent maybe to make decisions regarding that, and they can be recognized. But the main purpose of the advance directive is not about what happens after death; it's what happens before death. Well, thank you all very much. It was
Thanks,
great
everybody.
talking with you.
Thank you. Thank you. Thanks.